Welcome to the Peak Mental Performance Podcast with Joe Schillero, optimizing your mental health and athletic performance one episode at a time.
2, 1. And all right, welcome everybody. I am here with Dr. Jordan Tishler, and he is a physician who graduated from Harvard Medical School, was trained in internal medicine at Brigham and Women's Hospital, and he worked as an emergency physician for a number of years, and his experiences through that led him to opening his own private practice in Boston, Massachusetts area. It is called Inhale MD, and he is essentially does consulting for patients on how they can best utilize medical cannabis as a means of treating their conditions. And we're going to talk about what that means, what that care through his practice looks like, and just some facts about medical cannabis and its uses. So thank you, Dr. Tishler, for doing this today.
Oh, thank you for having me. It's a pleasure to be here.
Absolutely. And I'll just state for everybody before we get started that like all the subjects that we've been talking about on this podcast, we could probably do 100 episodes on the different arenas and different deeper details of all of these things. You know, we could talk about the law enforcement implications of recreational use, the financial implications, societal things. We could talk about history. We could go in a lot of different directions. But for today's purposes with Dr. Tishler, we're going to focus on how medical cannabis can be used in the clinical setting to help people and what his care methods look like. So that's what we're going to focus on today, and maybe in the future we'll go down some kind of different paths. But I think I would just encourage everyone that is listening to this to, even if you've had maybe some thoughts in the past of even when you hear a term like medical cannabis, you have your initial flood of thoughts, to maybe just kind of open your mind a little bit in this podcast to listen to some of these facts and some of the things that Dr. Tishler does in his practice. And I know I had my initial thoughts from when I was younger about cannabis in general, and as over the years has gone on and I've learned more, some of my perceptions have changed of a few things. So I think this will be good. Like anything, we're just trying to give people more facts and information to be able to weigh their pros versus cons scale. So that's what we're going to try and do here today. So the first thing I want to ask you, Dr. Tishler, is in coming from a very conventional kind of high-level medical background of going to Harvard Medical, studying internal medicine, being an emergency physician, you also, I had read that you did a lot of work with underserved groups like veterans. Working in a very conventional kind of medical setting, what led you to go move into now doing what you're doing with a private practice dealing specifically with medical cannabis?
Well, it was a long process, and really after 15 years as an emergency room physician for the VA, I had sort of by trial by fire become very much an expert in the treatment, at least of the acute presentation of various substance problems, and was really impressed by how dramatically so many veterans' lives were harmed and even, arguably ruined by alcohol and other substances. And by other substances, I mean prescription substances as well as illegal substances. That's a really tragic situation. We all know that the suicide rate is very high. The suicide rate in veterans is vastly higher than that of the general population of Americans. Then people started talking about medical cannabis back in 2012. We legalized that here in Massachusetts. And I sort of started to think to myself, well, gosh, I've seen all these guys so harmed by all these other things. I've never seen anybody sick from cannabis. Well, look, if you've never seen anybody get sick from this stuff, you have to start to think, well, maybe it isn't so bad. And if somebody out there is saying that it might actually be a useful substance, then it's worth poking your nose into that literature and seeing what's there. So after that, I spent a couple of years really immersing myself in this stuff. by which I mean the literature, not cannabis itself. And sort of, went into it as you might expect from the background that you've so handily described, my wife described, with a certain amount of skepticism. Also, my wife is a physician. She's also an internist, and she was even more skeptical than I. So, through this process, we learned that there's a lot known about cannabis, and which, unfortunately just doesn't get a lot of play in the press and in politics. But in the science, there's all kinds of good information. And when you really add it all up, you find, my God, there's really good evidence that this stuff can be helpful, A, and B, that it's not very harmful in and of itself. And then if you start comparing harms against other things that we use routinely, you start to say, well, gee, this is kind of a no-brainer. We should be doing this. Not willy-nilly, but in a thoughtful, constructive fashion, like we try to approach most things in medicine. And sort of coming to that conclusion, I then looked around at the landscape and thought, wow, I seem to be one of very few doctors who actually knows any of this stuff. And working for the federal government as a VA employee, they're never going to let me do this. And looking at my colleagues at places like the Brigham or Mass General Hospital or any of those other major private but federally funded teaching institutions, you realize that they're so beholden to the federal government that they're not going to let their doctors get into this. So I, thought the only way to provide this in a thoughtful, consistent manner to patients then is to get outside that system. And that led me into this idea of private practice. And then I tied it all back in because what I ended up doing is giving talks and lectures to my colleagues at all of these institutions so that they would become at least familiar enough with it and the science that then they weren't afraid of it, and able then to say, all right, this seems like a reasonable option for you, Mr. So-and-so. Now go talk with Dr. Tishler over there because he's the expert. And that really became the way my practice works.
That's excellent. It's quite an interesting story. And to your point, even about what information is out there, that was something that as I, even in preparing for this podcast and looking at some of the things you've spoke about, I was even didn't realize how much research there is out there because obviously, a big cry all the time is that we need more research, which we certainly do. And, it's difficult with the Schedule I designation for people to be able to do the research they would like. But that, there's still, over 20,000 of these research articles out there. And it's like there is quite a lot to sift through to see that there's certainly enough to allow us to be like, there's some paths that maybe we need to look down here.
Absolutely. I think you hit the nail on the head. Like, it's very much the politician's cry, and we saw this with Mrs. Clinton, for example, that, people would say, well, I don't know what I think, or I think it's an interesting idea. We need more research. And I would say, you know what, there's no field of medicine in which anyone would turn down more research. Right? I mean, there's plenty and plenty of data in the cardiology world. It doesn't mean that we don't treat patients. It doesn't mean that we don't have a sense that we have a pretty good understanding of what's going on, with more to come. And we change our treatments and our understanding as these things evolve. It doesn't mean that we stand still waiting for, the tablets to come down from on high. And when you're absolutely correct that right now, if you go into PubMed, which is the government-funded database of science, and you put in the word cannabis, you'll return greater than 26,000 studies. That's probably the largest number of studies on any single medicine ever. Now, it doesn't mean that all of those studies are brilliant. And it has to be understood that many of those studies were funded looking for harms that could then be used for political aims. But in many cases, those harms were not found, or not found to be, important enough that they had the political ramifications. And just for comparison, you look at our research into alcohol, and you get about 5,500 studies from the same search engine. So you realize that that there's just a vastly larger body of work out there, despite being hampered, as you pointed out, by the Schedule I status.
Absolutely. And my hope is, too, that people will, over time, be able to see that, because sometimes I think when people say, like, hey, they make the note about some of this research was done or even published, kind of people I don't think sometimes realize that, there's a lot of screening into what actually gets published, a lot of times based on what they want to find and whoever's funding the study. And, sometimes people will be like, oh, that sounds like just some conspiracy talk or something. But I think now at this point we've seen where it happened not only with tobacco in the past, but even with how dietary guidelines have changed in terms of sugars and fat and heart disease. And we've seen where research was kind of pushed in certain directions or even just interpreted in a certain way and guided into public policy, and how that's changed the more people have looked at it objectively. And I hope that's how people will at some point look at this topic as well.
Yeah, I think that's absolutely true. I don't know that I think that there's just a vast conspiracy or anything, but I do think that science is unfortunately supposed to be pure, but in reality is driven by both politics and funding. And the funding, of course, comes back to politics. It's somebody in, I can't remember, it was, I think, The Lancet published an opinion piece recently about how science should be guided by trying to solve problems. And he made a very eloquent pitch for this, but what he had really described, as far as I was concerned, was not science, but engineering, right? Which is really clearly much more goal-oriented. And what I thought he had missed was this idea that in science that we should be answering the big questions without reference to a particular type of outcome, because oftentimes we're quite surprised. And if we are biased ahead of time, we're going to miss things that would be either important because they're positive or important because they're negative. And that purity of pursuit is actually science's most valuable asset. And unfortunately, we corrupt that frequently through the process of being human beings.
Certainly.
You really got me on my soapbox now.
No, that's okay. That's good. I had, anytime I have a guest on, I always try to go listen to and read some content beforehand to get an idea of kind of where you're coming from. And it certainly got so many questions in my own head going. And that's one of the things that selfishly I love about this podcast, is that I just am constantly being forced to keep learning. And I think that's especially in the field of mental health, where we have so much work to do, that's how everyone should be looking at it. And as not only somebody who is trying to help people from a educational and health services side, and I've worked in emergency medicine in the past and things like that, but also as somebody who's trying to work on my own issues and my own health, you just always have to be trying to improve your toolbox, improve your tools, improve your understanding of the tools, and you can never get complacent. So I think these things are just really good information that's out there. So kind of to what you do in your practice, obviously we're going to speak a lot today mainly to the mental health side, but what are some of the common conditions people come to your practice for where they're seeking care?
Well, so, the way I tend to think about this is a little bit, thinking about symptoms versus diseases, or illnesses. That's the word I tend to use. And when you think about symptoms, it's actually somewhat easier because pain is number one, without question. And the reason this is important as a symptom is it spans multiple kinds of illnesses, and it doesn't entirely matter what the underlying illness is, so much as we're addressing an outcome of that illness, which is the pain. And if you look at study data, pain is by far the number one presenting complaint to physicians anywhere in the United States. And furthermore, it is the number one presenting complaint about which patients feel we don't do a very good job. And the sad reality is we don't. And that's in part because the tools that we have are very limited, right? Most people probably don't really think of it this way, but this is the way I think of it as a physician, is that we really only have three types of medicine. This is not including the cannabis, right? You've got Tylenol, right, which is effective for many things for many people, but basically it's in its own class. And then you have what are called non-steroidal anti-inflammatories, which is a long way of saying things like Advil, ibuprofen, naproxen, all that. But basically there are about 20 different agents in that class, but they're all in the same class and they all sort of behave more or less the same way. And then you've got opiates, right? So, and opiates have their uses. And I am not one to poo-poo the value of opiates, but they also come with a lot of strings attached, and we have ignored those strings for far too long. I must own the fact that I have always been acutely aware of those strings, and I always kind of one of the stingiest doctors when it came to opiates. And in the early 2000s, when there were all of these sort of national missives about, you should not be under trading pain and give people the opiates and stuff like that, I just resisted. And of course, the administration was not very happy with me. But in hindsight, I feel a little vindicated. But back on the topic, really, if you can't tolerate Tylenol or ibuprofen, then we're right into, or where they don't work for you, then you're right into opiates, and there's really not a lot of other options. So bringing cannabis into this discussion, raises our options by a very large percentage. And what we know now, from studies is that for chronic pain, and that's different from acute pain, but for chronic pain, the opiates aren't really very good pain reliever. Again, they may be the best that we have for this thing, but they're not particularly good at it. And it turns out that cannabis is also not super good, but it's at least as good as the opiates. The difference, however, is that all those strings that the opiates come with, cannabis comes with far fewer strings. So the way I look at this is if you have two medicines that are equally effective, but one of them is far more dangerous than the other one, which one should you choose, at least at first blush? And I think the answer there is kind of a no-brainer, that cannabis ought to be, our second line choice after the Tylenol and nonsteroidals, but certainly before we reach for opiates.
Certainly. Yeah, that seems to make a ton of sense. And I think, that's something that I do, something that I hope that this episode and all the episodes that I do with different guests can help people do is, I know people have asked you the question before of just very black and white questions of like, oh, is cannabis safe? Are opioids safe? And it's like, well, we're talking about a scale here. We're talking about pros versus cons, risk versus reward. And I think I try to always hesitate to just tell people something is inherently good or bad. We're looking at trying to make a weighted decision here. And to your point, something like opioids, and even a lot of psychiatric medications, it's like they can help in certain areas, but then you also have to consider those strings that are attached, or potential withdrawal in the future, or addiction potential, side effects. And I always kind of liken it to, a medication that has a lot of those strings attached. If anyone uses Excel a lot with spreadsheets, you know what it's like if you have this entire spreadsheet filled with equations and you go try to you just change one cell, and if you don't understand all the other ones it affects, it all of a sudden screws everything up. And
absolutely.
You think sometimes you try to address maybe one pain symptom with a medication like an opioid, or address a problem like sleep with a benzodiazepine or something, and it affects all these other areas, and the next thing you know, you're chasing all these other things that have become problems. And so I think people, when you look at, okay, what's the problem I'm trying to solve with my clinician, look at how can we solve this problem without creating or adjusting or, making all these other problems as well. And that seems to be where medical cannabis, when used correctly, can make the changes without as many of the collateral damage, I guess.
Yeah, absolutely. I mean, but even still, I think that we need to avoid the wishful thinking or magical thinking and understand that it is a medicine just like all other medicines, and we need to treat it with that kind of respect, and that it may be safer, but it isn't without, its issues. So you're right. It's like that spreadsheet. We just have to be cognizant of tweaking one cell may well affect others, and we have to sort of sit back and say what is going to least mess up the chart, as well as ultimately, if it does cause some of these downstream changes, is the patient better or worse off with this, or is there some other way to do this? So it's all a very intricate and complicated calculus, and I think that that's the nature of medicine, and to avoid that reality is creates a situation where we're destined to fail. You back several paragraphs ago had asked me about what other things that people come to my practice for, and I think that might be worth our returning to. You mentioned sleep a bunch of times. That's our number 2 largest complaint in the nation, and it is also the number 2 complaint that people feel is not well addressed. It's really quite true that conventional medications do not do a very good job at treating insomnia, and it's probably the single thing that cannabis treats best, actually. So that very, very small doses of cannabis a little bit before bedtime go a very long way towards solving sleep issues. One of the things, as an aside, that I would point out to your listeners is that one of the major differences between medical use of cannabis and personal or recreational use of it has to do with the approach. And in reality, my patients benefit from cannabis at doses that are so low that most recreational users would not even consider it real use. And so one of the things I battle with and worry about from my patients is those who come to me having sort of gotten their toe in the water from the recreational side, or with advice from recreational users, often end up using way more of this stuff than is good for them or necessary. And it becomes much more difficult, in fact, to sort of convince them that they will get better benefit and safer benefit from less. So I kind of wrestle with this a lot.
Yeah, that does make sense. And I guess kind of as a tangent with the sleep, maybe without going too far down this path, but with something like sleep, do you find that you are using cannabis to just help people fall asleep, or do you find that it improves sleep quality for them as well?
That's a good question. I think that everybody is a little different, so that the answer to that is, without question, it helps people fall asleep, and that they tend to report that they feel like they're very well rested. So I guess that addresses quality of sleep. The other part of the equation is early morning awakening. And so some people have trouble falling asleep, other people have trouble staying asleep, and then a third set of people often have trouble sort of benefiting from the sleep that they get. And so we talked about group number 1 and number 3, but this group in between is the group that sort of, they get to sleep fine, but then at 3 a.m. they're wide awake, and the rest of the night is a waste for them. And that one's actually a little bit trickier, because if you dose before you go to sleep, in many instances that has largely worn off sort of by 3 a.m, unless you use an oral form, which behaves differently from the inhaled form. And The problem with that is that it's a little bit unpredictable the way they behave. And number two, that sometimes they last so long that you wake up the next morning feeling a little groggy. So it becomes a balancing act. Most of my patients do really well with the small bit of inhaled about an hour before bedtime, and don't need anything further. The guys who wake up at 3 a.m, again, it really depends on sort of when are they supposed to be up for the day. Is giving them an oral before bedtime a better plan, or is it better to have them have a vaporizer beside the bed, which they can take a couple of puffs from when they wake up at 3? And that gets into some very individual territory.
Right. And I think some of those things you just spoke to kind of lead into what I wanted to ask you next. And it's kind of the process of consulting your patients and how you go about finding them the best solutions that you can. Like you've already kind of mentioned, you have a process and you're trying to find the best specific way to help somebody a lot of times reach the best outcome with the fewest side effects, because like we've said, cannabis is not a perfect medicine like any is. And for some patients I know as well, they're not even trying to have any intoxication, which is, inevitably they'll have some, but you're
Yes.
treating it more like a side effect. And
Absolutely.
so in that process, it is one of the downsides of different states having different laws. I know there are some states where there's medical clinics where people essentially go in, say something hurts, get the thumbs up, and then they go get some. And those would be on one end of the spectrum. And I think it's easy for people to see that situation and be like, oh, that's all medical marijuana is. But in a practice like yours, you take a very thorough approach in helping somebody get personalized care and educating the patient. So can you talk a little bit about when somebody comes in after they fill their intake paperwork out and they meet with you, what does that meeting look like?
Sure. But let me back up a few paces too.
Sure.
You're absolutely right. The card mills, we call them, exist. $200 in a pulse, and you too can have your card. And they exist here in Massachusetts as well. I just, don't play that game because it's of little interest to me. I'm interested in taking care of people who are ill and then would benefit from this. And I guess that makes me the other end of the spectrum. But I do take it seriously, and maybe that's that sort of Harvard, traditional training coming through.
Right.
Before we even get down to meeting, I request that my patients fill out a questionnaire, which gives me some idea of what they're looking for and why. And more importantly, even than that, is then they need to send me some medical records. So we ask for the last 12 months and that sort of thing so that I can review the records, which is really about understanding, what's gone wrong, what things have been tried and what are succeeding and what are failing, as well as other areas of their medical care, because we need to do this in the correct context, which means that, if we want to take a holistic view of the patient, then we really have to view the whole and, not just pretend that we're focusing or not be hyper-focused on whatever is wrong that leads us to think cannabis. And so there are, medications and allergies and past medical history are all very important. And I can give you a great example. I had a gentleman approach us some number of months ago for back pain. And, it was garden variety back pain. And it would be easy for me to say, sure, absolutely, come on in. Cannabis will be very helpful for your back pain. But I was reviewing his medical records and I realized that he had neglected to mention to me that he had had a liver transplant and was on a medication called tacrolimus, which is an immunosuppressant that is necessary for him to survive with this new liver. And not only is it necessary to preserve the liver, but it's a medication that if the levels get too high, can be lethal. So level too low, he rejects the liver. Level too high, he dies from toxicity. So, it's what we call a very narrow therapeutic index, but you can think of that as a very narrow window of safety. Right. And if I hadn't caught that, we could have caused serious damage to him, particularly because it's, cannabis, as you know, is made up of many, many component parts, like the THC, and also the other one that gets a lot of press these days, CBD. CBD, which stands for cannabidiol, is yet another piece of the medicine, and it's an important part of cannabis flower, meaning the flowering part of the plant that we use to treat people. But human beings like to monkey with these things, and so we certainly have a lot of people out there who are trying to use CBD by itself. And I think that the studies don't really bear that out, but it doesn't mean that people haven't made a market for it. But what's most important to understand in the context of the story is that CBD is the part that's most likely to interact with conventional medications. So if this gentleman had not, if I hadn't picked up on this and he had then gotten his card from me and I hadn't said anything to him about this, he could very well have gone into a dispensary where they give inappropriate levels of medical information, and they could have said, "Oh, you have back pain. Well, people say that CBD is good for back pain, so take some CBD," and that might well have killed him, right? And it's part of the reason that I think it's very important for us to take this sort of in-depth look at people's medical care, and for me to be able to advise them appropriately. And I also think it's why that the dispensary agents, aka bud tenders, should not be in the position of giving advice about what products to use, because they don't understand, nor do they have any right to the history of a patient who's standing in front of them trying to purchase medicine. So it's a complicated system, but this is why I take such an in-depth view. And I do all that long before I even meet the patient, just to make sure that there's nothing that makes this an inappropriate idea, so I can tell them that before they A, pay me, and B, make time in their life to then sit down with me. So that's all the preamble, and in many ways I think that preamble is super important.
Yeah, absolutely.
Yeah, go on.
Go ahead.
Go on.
Go ahead. No, go ahead.
No, I was just going to launch into the second part of your question, which was, and then what does this look like?
Yeah, I was just going to say, before you go into that, I think right there is just such a huge example of why I think people need to understand how that holistic, like, you need to take everything as part of the picture. And, to your point too, one of the things we try to encourage all of our listeners about, and our guest last week, Dr. Lonnie Lowrey, gave us a great example of this, is any intervention you use is connected to all the rest of your body's current, what you're doing with it. And a lot of times, trying to use an intervention when the rest of your situation isn't in the correct place is like trying to plant flowers in spoiled soil. And so you really do have to make sure you're addressing everything collectively, even if you are using one intervention primarily. So I think that's a great example. It's a great example of how that can even be life and death to a certain extent because of medication combinations and interactions and things. But
absolutely.
Yeah, why don't you go ahead and into the next kind of aspect of what you do with your consultation?
Well, so if somebody does then come into the office, one of the nice things about being in private practice is that I'm not beholden to the insurance companies, right? So I was able to set it up in a way that allows me to practice medicine the way I believe it should be practiced and the way I feel the patients want it to be practiced. So, everybody's first meeting with me is an hour. When was the last time you went to a doctor and had an hour appointment, except maybe a psychiatrist, right? And so we sit down and I talk with them about what it is that's going on with them and really sort of get them to reiterate what's, not just what's historical, but what's current and what's troublesome to them. And really the point of that is to understand what are the goals of care. because everybody comes in with a set of symptoms that are, linguistically not unique. That is, say, pain is a word that describes things for different people, but everyone's experience of pain is uniquely theirs, as well as sort of what it is that they hope to accomplish is uniquely theirs. So we talk a lot about that sort of thing. And what are their fears and worries about cannabis and stuff like that. And then I have an entire packet. It's one of these sort of green pocket folders, and it's, everyone goes home with one of these things. And sort of on one side of the folder, we have a bunch of sheets that we then go through that are sort of a cannabis 101. And on the other side, in the other pocket, then we have what sort of is kind of like a little prescription that then they go home with, so that they can, number one, remember what I told them, but number two is take that over to the dispensary and help, the sheet helps the dispensary people find what it is that I'm recommending to them, with hopefully a minimum of negotiation, shall we say. And so we sit down and we go page by page through this packet that I've developed over time by responding or listening to and then responding to patients' questions. And it talks about things like strains, strain potency, how do you choose a strain, which, by the way, I think the answer to that is mostly by its potency, and frankly, lower potency is more useful for patients than higher potency, for a number of reasons that are probably beyond the scope of our discussion today. We talk about different ways that you can use cannabis, meaning how do you take it into your body? And what's interesting about cannabis is that you can use it in many, many different ways, and it behaves differently depending on how you take it, so that inhaled cannabis, notice I don't say smoked cannabis, but inhaled cannabis is different from orally taken cannabis. And then there are, and in fact, in many instances, these differences in the behavior of the medicine can be used to our advantage. So that for some conditions like insomnia, anxiety and depression, those sorts of things, using inhaled cannabis where it has a rapid onset and a sort of moderate duration, meaning sort of 3 or 4 hours of action, that's actually a good thing, right? I mean, it allows us to kind of get in, get what we need from it, and it doesn't hang out too long. And, that's also useful when pain gets out of control. When patients have occasional pain, again, inhaled is very useful. When patients have 24/7 pain that's really disruptive of their lifestyle, then we want something that's longer acting. And that's where a lot of these oral things come in, because their time to onset can be problematic in that it's not only longer but variable. But if you're going to use this sort of around the clock, and the duration of action is much longer, meaning kind of 8 to 12 hours, then it becomes useful. So again, it's all very individualized by what's wrong and how does this stuff fit into your lifestyle. And then there's a whole sheet I go through of products that I think patients should be avoiding completely. And really this gets back to some of the stuff we've kind of touched on, which is that the dispensaries are not required, at least in Massachusetts and most of the other medical states, to do what I tell them, so that the patient is in this very unusual and awkward position of having to say, I want X and only X because this is what my doctor told me, and you're offering me Y and Z with a little bit of arm twisting, and I have to resist Y and Z because I don't know what they are, and my doctor told me that I shouldn't get those things. When we go into a CVS or your local pharmacy with a prescription, there's none of that kind of arm twisting and negotiation, right? They sell you the medication as it was written. And people, I think, often get this erroneous idea that the prescription is there to control meaning the patient's behavior. And really, except in the very rarest instances, that's not the point at all. It's rather to constrain the pharmacy from over exercising their profit motive, right? By upselling and cross-selling products that would not be appropriate. So we don't have those kinds of protections in the cannabis industry. So I unfortunately then have all these sheets on, that are sort of defensive that way to try and educate people about how, these other products that exist are not really good for them. So there's that. And then we talk about vaporization and how do you do that and why would you do that, et cetera. And then we get into some nitty gritty stuff like cannabis is probably not a great idea while you're pregnant, which is not to say that we know that it's bad, but we just don't really have a handle on it just yet. There are certain people who should probably not be inhaling cannabis, people who have certain immune suppression diseases, particularly related to current chemotherapy, stuff about workplace protections, which vary from state to state, things about driving under the influence, things about traveling with cannabis, and then we get into the really nitty gritty of like how do you actually sign up in Massachusetts and stuff like that. So that's kind of the stuff that gets folded into this discussion, and at the end of all that, then I haul out this prescription sheet and I say, based on everything that we've talked about, here's my recommendation, and I start checking off boxes and filling in details, so that they have something then to go home with and to go to the dispensary with.
Excellent. I think two of the themes that pop out to me from what you're discussing in your process and what I had researched coming to this interview is the idea of personalized care and the idea of patient education. And I think those are just two things that, even outside of this arena in all of medicine, that could just be done such a better job of for patients. And I think, I know and a lot of it, like you mentioned, is when you're under the constraints of not having your own private practice, most doctors are especially in an emergency setting, are very overbooked, all these different kind of things feeding into it. So it's not necessarily always the medical provider's fault by any means. But I think a lot of people are in a boat where they, especially in something like pain management or mental health or, one of these things, they go through years and a ton of different doctors of just always feeling like they're just kind of riding this crazy wave, and they're not really ever learning about their condition or learning what they can control or feeling like they're getting anything sort of specific advice. And especially for something like mental health, where a lot of their life is probably feeling very out of control, I think there's probably a lot of value that your patient's seeing and being able to be like, here's some things I can actually control. And I'm sure there's a lot of comfort in just being able to get some information and to just feel like they're making a step forward in something that can help them. And I'm sure that patient education aspect is something that they really appreciate.
I think that's really what it's about. I mean, anybody can go buy weed somewhere, right? I mean, That's, even if it's illegal, you can still go buy weed somewhere. So the real question is, and the same could be said for Seroquel or Percocet or lisinopril, which is a blood pressure medication. You can always get your hands on it. The question is, why would you, and what are you going to do with it, right? So in essence, unless you're a surgeon where you're actually doing a procedure, really what medicine is about is guidance and education and sympathy and support and and being available as a sort of a partner in somebody's well-being. And I the truth is, you're right. In the United States, we've got a problem with people who feel that they're not getting what they need from their doctors. The irony is we've got a huge group of doctors who all went into the medical field because they wanted to give those people exactly what they're looking for, and who are feeling absolutely miserable and beaten to a pulp. And there's an entire scientific literature emerging around this stuff, where the doctors are just, so beaten to a pulp that there's nothing left to give. And if you
Right.
really think about it, if in order to make the clinic work, you have to see a patient in 10 minutes, every hour for, whatever that is, 8-ish or maybe 7-ish hours in a day. By the end of that, there's no human being left in that white coat, right?
Yeah.
So we have a problem in this country where we have a mismatch between what the providers want to provide to the patients and what the patients want from their providers, and some external force, aka insurance, that is standing in the way of these two groups meeting in the right spot. And I think that's horrifying. I have really been very fortunate, I think, to be able to carve out this niche where I can then really sit with my patients and try to understand what they need. And the other thing is, we need to reimburse physicians and practitioners of all sorts in a very different way, because, for example, I give my patients my email address and I tell them, email me. I rather like to hear from you guys. Let me know how things are going. If things are going well, I like that to hear that too. If they're not going well, I definitely want to hear that, because let's see if we can fix it. And I think that goes a long way with my patients. They seem to really dig it. I'm also find that very few of them actually take me up on it. Sometimes that's a bad thing, because then I hear 6 months later that things didn't go smoothly, and that's too bad. And I tend to just reiterate, why didn't you call me? Why didn't you email me? That sort of thing. But I think that for a lot of my patients, things do go smoothly, but they just have this confidence that I'm there and available for them. And then there's a group that really, needs more fine tuning, and we do a lot of that by email. And it means that it doesn't have to take up a heck of a lot of time in my day to get them what they need. It doesn't require that they sort of rearrange their schedule to come into a meeting to essentially answer a 3-line question. And that really works very well. But on the other hand, if the reimbursement situation is such that means that work is getting done and not compensated for, then you got a problem. So we've got to start thinking, and this has nothing to do with cannabis, but everything to do with providing care to patients. We need to start thinking more broadly about how do we make this work for the people who are needing the work and people who are doing the work, and a little bit less for the bottom line of the corporations.
Absolutely. I think those are some great points, and I think to your points as well, that's why I've tried to encourage people of, I've had a lot of years of a lot of frustrating situations with my medical care for myself with some of the issues, but I think it's a good idea that we don't just demonize doctors or demonize medications or hospitals or anything in particular, because there's so many moving parts that it's the system itself needs fixed in the processes in a way that allows people to do their jobs in the way that they need done. So I think it's good for people to hear that perspective too, so they don't just feel like it's, oh, the doctors don't want to help me, they just, whatever. It's like a lot of times you're not seeing things behind the scenes that they're working through too, and in a lot of cases their hands are kind of tied. So like to your point, I think the industry, I guess, as a whole, if we can keep pushing for changes to be made in the right direction, I think that'll help patients and doctors.
I'm sure that there are asshole doctors out there,
Yeah.
but I got to tell you, and I'll also own that I live in Boston, where we have, some very high power institutions that recruit doctors of a certain stripe, but I don't know anybody who's in this business for any reason other than wanting to help patients. So, I realize that other people may have different experiences, et cetera, but that's just, my perspective on it.
No, I think that's a great perspective to remind people of. So with your patients that come to see you, a big part of what we talk about today is, I think there's probably medical cannabis is probably one of the topics that has the most societal and emotional kind of pre-assumptions linked to it, where people may not know a whole lot about it, and they kind of usually anybody, it's like you say medical cannabis and they didn't even hear medical. All they think is like weed. And what does that mean? And so when you have a lot of your patients coming to you, and maybe you have some that, they're not really, this isn't maybe even their first option, but they're kind of just at the end of their rope, they may have a lot of reluctance when it comes to using cannabis if it's something they've never done before. What are maybe some common fears or areas of reluctance that people come into your office with that you help them work through as you address their care?
Absolutely. In a lot of the, you are right. People come in with all kinds of preconceptions, and you can't blame folks for this, because reality is, we're pushing on 90 years of its being not only illegal but demonized, to use the word you had used.
Right.
And if you think about it, that when we talk about social science, 30 years is sort of a generation, right? And what we're talking about is then 3 generations of Americans who have grown up being told that this is the devil's weed, and without that being in reference to anything other than politics. There's never been science to suggest that illegality made any sense. So people definitely come in with all kinds of ideas. So, one of the things I think would be helpful is for me to describe some of my average, patients.
Sure.
Imagine an 80-year-old frail lady with, snow white hair and the crinkly, a twinkle in her eyes. And that might be describing quite a number of my patients. And they might be coming in because they have back pain, or they might be coming in because they have anxiety, or they might be coming in because they actually have cancer and a whole host of other things associated with it. But, they're not a teenage pothead, is what I'm getting at. And many of them have never touched cannabis, or maybe they had, quote, one puff back in the 60s and it didn't do much for me, or I didn't like it, or something. That's their background. And so I get things like, I want to feel better, but I don't want to get high.
Right.
Okay. And what I say to them is, I understand that you don't want to get high. The way we look at this in the medical context is intoxication. The words I choose are kind of specific. So intoxication, I don't talk about pot or weed. I talk about cannabis. I don't talk about bud or, stuff like that. I talk about flower, because anatomically it's the flower of the plant. So I say, look, the intoxication here is a side effect. It's not what we're after, but it does come with the benefit. And then it becomes our job to manage your care and the medicine in such a way that you get the best benefit with the least side effect, which frankly is the way we do any medication. And I think that helps people sort of start to understand that, number one, there's no free lunch, that all the websites out there just saying, you don't need to get high is not true. And number two, that, the focus on getting well is where the emphasis should be, and that the intoxication that comes with it is neither the focus, nor is it such a bad thing. And then we sometimes get into discussion about how many other conventional medications, while they're making you better, make you feel really lousy. And why is it that it's wrong to have a medication that makes you better and also makes you feel better rather than feel lousy? And this was something I actually had a bit of an epiphany about, because I actually ended up with a bellyache at one point and was put on some antibiotics, and I ended up concluding that the antibiotics were more unpleasant than the bellyache ever was. And then I toughed it out and everything was fine, but it made me realize that our treatments aren't always as benign, even if they're successful. So, that's certainly one thing that people come in. The other thing I hear from patients a lot is, I'm not going to smoke. as though I were going to twist their arm to
Right.
light up a big fatty or something. And I usually try to restrain myself from saying something sort of snotty like, "That's good, I don't want you to smoke."
Right.
You'll notice, getting back into that linguistic stuff, you'll notice that throughout our conversation, I said inhaled. Inhaled cannabis has those advantages, but I don't recommend that people smoke it because smoke is full of crap that doesn't belong in your lungs. Whereas vaporized cannabis does not contain all of that stuff because we're not burning the plant material. And let me also take a moment to say, and people may be getting an impression here, that when I recommend vaporized cannabis, it's vaporized flower, which is again the plant part flower. And I don't particularly think that vaporized cannabis concentrates or the little vaporizer pens are a good idea. And there are a number of reasons having to do with chemicals that are in them and dosing. So that I think that there's, a lot of detail around how do you dose this and how, what products do you use for best benefit and best safety. But again, when patients come in and they say, "I don't want to smoke," my response is, "That's good. I don't want you to smoke. But let's not throw the baby out with the bathwater and say, I'm not going to inhale anything simply because we associate inhalation with smoking when they're really quite very different things, and that we use inhalation in conventional medications as well." So, that's another thing that people come concerned about.
Yeah, I think those are great things. To address, because I think there's a lot of people who, even if they're in a state where it's legal and they even have access to somebody like yourself, for a lot of people, there's going to be those inhibitions. And then on top of that, you throw the stigmas of the conditions they're dealing with, like mental health on top of that. And you just got a lot of people working through a lot of their emotional state as they come in to try and get care. So I think, education, and that's a big part of this podcast, is you can educate people that you can come in feeling, a little more educated, a little more empowered about this area of care than I think people see. It's not as intimidating as as maybe they thought it was.
Absolutely. The other thing that people interestingly don't ask me about very much, but I think they may worry about it, is sort of the it's addictive trope. And, that's probably something worth touching on for your audience. And when people do bring this up, who brings it up more often than the patients is the physicians and other clinicians that when I'm giving talks. And in fact, I have a series of slides now dedicated to this issue. Cannabis, first of all, it's always worth making a distinction between addiction and dependence. Dependence is a biochemical process, meaning that your body essentially adjusts to the presence of a chemical or a medication, and that if you then don't have that medication any longer, your body says, "Hey, I was used to that. I'm going to give you trouble until you give it back to me because I've gotten used to it." And we see this with alcohol, and we see this with opiates, and we see this with the benzos. But it's not an uncommon process with other medications as well. That's, physiology, and really doesn't have much to do with psychology or moralizations. And we do see some of that in the in cannabis use. So whenever you think about these issues, you have to ask the question, sort of, what is the likelihood of this happening to any individual? And then the other thing that is often forgotten about is you also say, in the event that it would happen, what are the consequences, right? So, For example, benzodiazepine dependence occurs in 18% of users. Now, if you think about it, 18% sounds like a lot until you say, well, 82% don't. Right? You go, oh, well, that's much more than half, right? So, 18% doesn't look so bad anymore. But The other thing you have to ask is, if you stop taking your benzos cold turkey, what are the problems that arise? And the reality is that
not good.
not good at all, right? I mean, you can end up with seizures, and in fact, it can be fatal. So, cold turkey with benzos is probably the worst idea. Now, you look at cannabis, and the numbers for, the incidence numbers for this dependence is somewhere between 7 and 9%, which means you're well into the 90% group that don't have any issues at all. But then again, you also ask, and suppose I were to develop a withdrawal syndrome, what is going to happen to me? And the answer is usually sort of between 3 to 7 days of crankiness, insomnia, and some anxiety. Like, that sounds strikingly like the things we might have been trying to treat, right? Mm-hmm. So the point is, you don't have seizures, you're not going to die, you're going to feel kind of cranky and crummy for a few days, and that's about it. That's a whole world away, in my mind, from what we just talked about with the benzos, or even opiate withdrawal, which can't be fatal, but it's certainly miserable with sweats and cramps and vomiting and hypersensitivity and all those sorts of things. It's just, those don't happen with cannabis. Just the risk ballpark here is just very, very different. And just for reference, I often, when I'm giving a talk, say, how many of you people can't get your day started without a cup of coffee? And, like a huge number of hands go up. And then I say, well, the dependence rate on caffeine is exactly the same as that for cannabis. People go, oh, really? Well, we all love our coffee, and that isn't doing us a world of damage, and we're not, jumping off bridges or off tall buildings. And you go, yeah, that's right, and neither will you if you're using cannabis.
Yeah, I think that's a great point to drive home to people, and to the bigger picture of what we're talking about, and this is one of the reasons I've wanted to have on this podcast to be able to discuss this topic. But as I'm sure it's a lot of people are either irrationally anti this topic, or they're for the topic, but they're just kind of a little
equally irrational.
Yeah.
Yeah, there's definitely that.
They're so kind of googly-eyed about the whole thing that they have a hard time providing facts that aren't just very wishful thinking of, it's the answer to everything. And
yes.
I think what I appreciate about your perspective, and what I would like people to be able to view this as is set the emotions aside, and let's look at the pros, the cons. Let's look at all the variables, and let's measure out the role this has in your care. And there's, like anything, there's the risks, there's the side effects. But I think people would find that if you took, and this is what I've come to realize over years of being on a lot of different medications that in hindsight I wish I wouldn't have been on, but it's been a learning experience. And I think if you sat down and you look at these different medications that may be prescribed to you for your condition, and you just look at rate of effectiveness, side effects, potential of dependency, different withdrawal variables, things like that, and then you do the same thing to medical cannabis, I think people would be surprised that if they took the names away, their
right.
their
blind
decisions,
taste test.
Their decisions might be a little different than maybe when they're kind of clouded by those societal perceptions. And that's all we're asking people to do is start taking these facts and start weighing things maybe that way, versus instead of just getting blinded by this kind of what the politician said on the TV.
Right. And the other thing is, you're right. Exactly. I like this idea of the blind taste test. I think maybe I'll make a video of that or something, and just sort of describe a bunch of characteristics, and then do the great reveal and show that, it's Coke versus Pepsi or whatever. But, there are also people with illnesses, who probably shouldn't be using cannabis. And, one of the questions you had asked me earlier was about people with schizophrenia. You know, a lot of the data that we've had up until now has made an association between cannabis use and schizophrenia. And an association, of course, is just that these two things seem to kind of go together, and it doesn't really tell us which one is causing the other. In recently, meaning within the last year or so, we've really started to get some closer handle on this to go beyond association, and really at this point can say that if we have reason to believe that somebody who is not yet shown that they will become schizophrenic, that they probably shouldn't be on cannabis because it may in fact be, cause or promote their schizophrenia. Now, the problem with that, of course, is how do you know, where's the crystal ball? How do you know somebody's going to become a schizophrenic? And the answer is we don't really have a handle on that yet.
Right.
But there's some feeling that in the near future we may have some genetic testing that may actually lead us in that direction. But the correlate is, you know, if somebody has schizophrenia or any other sort of psychotic illness, then probably they're not a good candidate for this medication. And, you know, again, some of this is just kind of really trying to make sure we're not causing problems, right? And that's good medical care.
Yeah, I think that's a great point. And I think to the common fears people have about it, you know, I think probably similar to the addictiveness, you know, people have that fear of, oh, it's going to be a gateway to harder drugs, and, you know, I'm one step closer to using something incredibly dangerous. And I think people would find, if they looked more into that research too, that it's a lot of times a similar, like, they looked at people that have used those harder, more dangerous drugs, and then they saw that those people had also used cannabis, but there's a lot of variables that are not, it's a bit of a jump to say that they used those because they used cannabis, you know.
Right.
I think that's what people have to realize. It's, you know, a lot of times those people, they also just happened to use cannabis because it was a more accessible drug. It also was essentially something that was helping them fill that void that they were trying to fill. You know, there's a lot of rather not causational aspects of it.
Absolutely. If you take a group of heroin users and you look back at what they did, that is not the way to prove that what they did in the beginning landed them where they are. What you have to do is you have to take a group of people who, you know, all look the same on day one and follow them forward through their lifetime. And if you can show a progression, you know, Johnny started with weed and then went to heroin, and that happened more than, you know, people who never started with cannabis, then maybe you've shown some causation. But that sort of study has not been done. Well, I don't think that's fair. Those studies have been done, and they have not shown causation. And I think that, except for in certain political circles, it's pretty clear that the gateway hypothesis is dead. And, you know, let it rest in peace.
Yeah, that's good. I wanted us to touch on that because I think that's probably one of the common ones people think of when they think of this topic.
You know, it's worth noting, actually, that, you know, what I just said was slightly wrong in that the gateway theory as it applies to cannabis is dead. When we actually do those studies looking forward at people's use, it tends to be alcohol that is the gateway drug. And, you know, but again, we went back and we tried prohibition of alcohol, and it didn't make life better. So the approach to these things, again, always has to come down to some common sense and some education and provision of services for people who, you know, run afoul of these substances.
Absolutely. And I think one of the difficulties, along with that prohibition aspect you mentioned, that we deal with athletes is, like I said, we find more and more in this country that a lot of athletes deal with mental health conditions, maybe some pre-existing, some that are compounded by their sport or training for their sport, and they're in a difficult position because WADA and many organizations not only prohibit cannabis use, but it will, in cases like the NFL and things like that, you can get suspended and fined quite a bit for its use. And I think a lot of athletes are in a tough position because we see so many of those athletes in something like, say, the NFL, that once they retire, many of them go on to have issues with pain medication, addictions, and things like that. And so that's my hope, is that in the future, as more education gets out there, that hopefully athletic bodies will start to look at maybe cannabis through a different lens, because so many athletes are using more dangerous means to help them with the pain or the mental health associated with their very highly kind of not abusive sport, but sport that
physically
really wears
abusive.
on you. Yes,
Yeah, no,
absolutely.
you're absolutely right. We didn't mention it before, but I am the treasurer and board member of a group called Doctors for Cannabis Regulation, and our the gist is the war on drugs as it applies to cannabis has become a public health nightmare in itself and has failed, and that we think that these medications, or rather I should say cannabis, should be legalized and regulated in a way that provides for people's safety and ceases this punitive incarceration of people for use of the substance. And we were working very closely with a number of, at this point, retired NFL players to bring awareness to their plight and their condition after having retired and become older and, frankly, just in more chronic pain, and the ways in which their use of cannabis was completely shunned by the NFL while they were active, but has become a very important part of their health care and well-being once they were no longer beholden to the NFL. I think that there's a lot of traction around that idea. There are, ongoing discussions to try and get some active players to come forward and talk about what they're doing. And a lot of discussion with the Players Association and with the NFL itself. It's really not clear what the NFL's position is evolving into, because, for example, in the last week, they withdrew from a partnership with the National Institute of Health, which was aimed at doing a lot of research, not specifically about cannabis, but about CTE and concussions. Mm-hmm. And they kind of withdrew from this thing without kind of living up to their end of the bargain. And in the same week now, they've announced that they have at least are willing to discuss with the Players Association doing research on cannabis as an alternative treatment for players. So I think the NFL is trying to find its way around some of these major issues that are confronting players. And it's just unclear kind of at this point where it's going to head and how they're getting their advice on the topic.
Yeah, absolutely. Those are some interesting things that I'm glad you shared. And maybe in the future, if time permits, maybe I can have you on again and we can discuss some other variables of this topic. But
love that idea.
We went over some really great information today, and I think it's enough, to at least get some people the wheels turning on maybe looking into more information about this. And I think both your and I's perspective on this topic to people is again, we're not telling anybody you need to use this, but
right.
I think everybody can benefit from education. Is such a powerful thing. Learn more about a topic and you're just going to be better off in making decisions about it, in helping other people with it. Currently there are 29 states that have medical cannabis laws, and the path continues the way it is. More and more will probably have it on the ballot, and so people are going to have the ability to change the laws with these things. And it's good to continue to educate yourself, especially because there have been so much bad information out there.
Absolutely.
And especially for the reasons that you noted about the athletes and seeing that, this is an area that that this can potentially be helpful to athletes for. So your website for your practice is inhalemd.com, and I know you have some blogs and things that you post on there as well. For our listeners, if they want to learn more about this topic and just continue to educate themselves better on this, on the facts surrounding medical cannabis, what would you suggest to them of kind of some things they can check out?
Well, the problem with answering that question is that there's a lot of information out there and a lot of bad information out there.
Right.
So I think that, for people who have had the opportunity to listen to me and don't think I'm a complete nutball, I would suggest that they go to my website, which again is inhalemd.com. And I do have a blog. It's got about 100 articles there at this point. You can now search on it, so you don't have to wade through all 100 of them. And particularly with regard to the folks who might be listening who have thoughts about their mental health, and also for those who are athletes, I've got a number of articles on those subjects specifically. And then the other thing I would mention is that, once you've waded through some of this stuff and are thinking maybe that this medicine might be helpful to you, I do online consultations so that my practice is not specifically limited to the Massachusetts area. And this works really well for folks as a way of kind of getting information and advice on how to use this stuff in wherever they live. And I've taken care of patients in, Florida and in Texas and in other countries as well, just using telemedicine.
Great.
So I would encourage people to take advantage of that.
Yeah, that's an incredibly, it's one of these great benefits of technology now is that we can do things like that and information can be spread in the right way. So
exactly.
Thank you, Dr. Tishler, for taking the time to talk about this today. I think it was a lot, and I'm sure people will really benefit from this information. I had already had a few people tell me they were really looking forward to this episode and hearing you speak. So I think, I think this was great, and I really appreciate you taking the time to do this.
It's my pleasure. Thanks for having me on. It was awesome.
Absolutely.